We're going to have a little video first and to sort of settle things down. A great session earlier. Everyone agree? Yeah? This is going to build on that. So, Hubert?
Hello, my name is Connie Post, and I'm a mother of a son named Thomas, who's 36, who has profound autism and intellectual disabilities. I've spent much of my life advocating for his medical and dental needs, and part of that has been finding dentists who can care for his oral health. I can't tell you how many dentists I've spoken to and described Thomas's situation who felt certain they could deal with it, and then when it came down to it, were really unable to deal with his situation. Very basic things like how to get a client to open their mouth when necessary, how to brush their teeth, how to tell when they're in pain because Thomas doesn't speak, and it's really important to be able to understand those kinds of things. Health equity is very much needed for people like my son, and we shouldn't have to travel many miles to get this care. It's very hard on the client and the families both. My true hope is that someday, soon people with disabilities can be seen in local offices, then not have to go too far, and that these offices will adopt the health curriculum, the oral health curriculum of the American Association of Developmental Medicine Dentistry, which is vital. I really, really hope that this message goes through and that these kinds of things can change for people like my son. I'm going to read a poem about my son from a book I wrote called And When the Sun Drops, and it's about the experience of him being nonverbal. The title of the poem is Nonverbal. People often ask, since he can't speak, how do you know what he wants? Which is often followed by a moment of my own silence. How do I know when it's dawn? How do I know when the fog rises up over the eastern hill? How do I know when Orion is stretched out across the autumn sky? I hear your footsteps as you come downstairs before I'm out of bed on Sunday morning. Each measured footstep like a faraway drumbeat I have become accustomed to in a dense forest of silent blooms. Thank you.
Thank you, Connie. A parent, an advocate, is always crying for help, and it's our job in terms of health equity to be that voice and to elevate that care. And we're pleased today to present a panel to discuss this a little bit more. I'd like to welcome our chairman of the board, my dean, Nadir Nadershahi, for a few words, and thank him graciously for helping elevate this very important topic. I want to thank Hubert Chan for helping us coordinate this. Dean DeGoey.
Thank you. Thank you, Alan. You all hear me okay? Yeah. Alan, thank you for saying yes, along with all of our panelists, to have this conversation. This is critical. You just heard from Connie. I was, some of the privileges we have being in oral health care and especially in oral health education is when you hear back from the individuals whose lives are touched by the work that we do. And she wrote the most beautiful note to me, and I didn't treat Thomas. Alan and the team and others that help support the clinic did that, but how much it meant to her, and then the beautiful poetry that she had. She shared her book. I mean, this is the impact. There are individuals across this country from different backgrounds with different disabilities that don't have access to care. And this is part of the reason why I really wanted to elevate this as one of the chair of the board Symposia. And as many of you know, we're really excited to have a resolution before the House as well that talks about the importance of this work and continuing to do this. So we're training all of our practitioners to care for individuals with intellectual developmental acquired disabilities. So thank you for making the time to be here today. Thank you again for our panelists for leading the charge with this work and helping all of us do better, because as a profession we really need to. So thank you. Enjoy the program.
Thank you, Dean Nadershahi. Again, it takes leadership to bring up what's important, and it's not always easy. March happens to be a wonderful month to have a conference. It's also a wonderful month for National Developmental Disability Awareness Month, if you didn't know about that. And highlighting, to start out with the first week of the March, is spread the word to end the word. Our word, retard, is a word that is kind of offensive to many patients and families, and it's our obligation as healthcare providers to remind healthcare providers that that word is no longer acceptable. It's no longer a diagnostic word. It was switched out for intellectual disability, for those who don't know, but education is key. Also, on March 21st is Down Syndrome Awareness Day, and that's 3/21, trisomy 21, and that's an awareness day. And it's also March is World Oral Health Month, so many things are great in March, and one great thing is having a great panelist here to help share with you a lot of things. And it's almost like fitting 20 pounds of grocery in a 10-pound bag. I've got so much information to share with you. Fortunately, all the slides are with you and are attainable, but in front of you, hopefully, for those who are in the front tables, there's a sheet of paper there, and we're gonna take a quick 5-minute get to know each other around the table. And I want you to take a look at the question sheets that are in front of you. And it says, do not start until you are given instructions. But I know all of you've already started, right? Right? You guys are OCD that way, that's good. So get to know each other, and I want you to pick 2 questions just to talk about and think about, and we're gonna be with you in about 3.5 minutes to share with you some information, some highlights of our progress so far as we go through this journey together, learning more, sharing more, okay? So go ahead, you got 3.5 minutes, all right? Get to know each other. Those in the back, move forward, make new friends, all right? Like to welcome those just coming in. Come on to the front, join the table and the crowd and the audience and meet new friends. I'll give you another 30 more seconds to chat about some of the questions in front of you. Get to as many as you want to, or whichever ones you like to. All right, hopefully you had a chance to talk about some questions on your table, and maybe not, what you had for breakfast, and where to get a Starbucks, that sort of things. I'm sure that's important. But this topic affects everyone, and I'm guessing each of you knows someone, or has a family member, or even have a child, or someone who has such a situation with intellectual developmental disability, or disabilities in general. And health equity means to elevate the conversation and make sure that our dental students and oral hygiene or dental hygiene students and assistants are well equipped to take care of this population, because we can't keep kicking the can down the road thinking someone else is going to do this. We have an obligation. It's a kind of important one. So this is about moving forward together. The theme that we have, impossible, is I'm possible, but really it's we're possible. We're possible because we can come together, talk about things, and create solutions and new solutions. So there he goes. Just put away the clicker. So we're looking forward to talking about this. I'm your moderator. My name's Alan Wong. I'm from the University of the Pacific School of Dentistry. And I have 3 wonderful presenters with me today. And we also have Macmillan Publishing in the back that's also working with us on this national curriculum project that's meant for all of us to share for free, because we believe that this is an important topic that we all can put together our heads and create something new. So on our first slide, I want to introduce Dean Mark Wolf from Penn Dental to come sort of set up the stage in terms of what we're trying to do here. And our learning objectives you have already. And I'd like to welcome Dean Wolf here to talk about framing the issue. Dean Wolf.
Thank you. I've been fortunate to be part of a school that has joined an extremely strong commitment to educating every DMD student as well as AEGD students, graduate students, in how to deliver dental care in their offices when they graduate for a variety of individuals with disabilities. My goal today is to actually kind of set the frame of why and where and how it becomes both a moral and physical imperative for us to make sure that all dentists, dental hygienists, and dental specialists manage to treat a significant population of persons with disabilities through the life cycle. I have no conflicts of interest here. So if we look at this statistic, which does come out of American statistics only, 1 in 4 adults, 26%, have some form of disability. If we're fortunate enough to grow into our 80s, 1 in 3 will have a disability that affects our ability to function, our activities of daily living. It's a significant issue in the United States, and it's a significant issue globally. The World Health Organization estimates that there are over 1 billion people with disabilities that affect their ability to function and be part of society in a fashion without assistance from a caregiver in some format. Within the United States, it's about 51, 57, 67 million, depending upon whose statistics we look at and the definitions. The implication of that is that if we're counting on making a special dentist to treat persons with disabilities, how many dentists do you need to make and distribute equitably throughout the United States to touch 50 million, 55 million, 70 million? This is the most rapidly growing portion of our society today, are persons that have a disability that interfere with their ability to function in society without accommodations, without the help of caregivers and other changes. And we have to really flip our thinking about how we address oral health care in a population this size with this many disabilities that needs assistance. The number one complaint for families and individuals is really just finding dentists. Somebody that cares enough to look inside the mouth, to see what accommodations, to see what disease, to pay attention. Throughout our entire region, there are individuals that will tell the story that I called the office, said that my mother is in a wheelchair, or that my child, or that I have an adult son who, and are instantly told, literally at the moment of the telephone call, oh, you'll have to find a different dentist. We cannot deliver that, without finding out that the person could be transferred into a dental chair, sits, the question never even arises. Where do we have the right to turn away nearly 1 in 4 adults in a population because they come with a disability? We don't have that right. The second issue actually goes to compensation. Many of the persons with disabilities whom we treat take longer to treat. They use different treatments, adults with fluorides and atraumatic restorative therapy, and items that may not be covered under current payment plans. It's our obligation as a dental education association, as a group of dentists, dental hygienists, allied health professionals, to stand up and say every person with a disability, regardless of their age, has the right to oral health, and we need to find ways of compensating the health provider appropriately for the care that needs to be delivered. These two items turn out to be the lion's share of issues. You know, a person with autism who's 19 years old turns 21, and they just become ineligible for care all over the United States. Not all over, in many locations all over the United States. That's a terrible thing, and it is our obligation to advocate to do something better for a very substantial portion of our population. We all understand the implications of inflammation in an aging individual, that we leave being sick because it's more difficult to clean their teeth, so we just don't care for that individual. Or worse than that, we pretend we are just by doing an examination in a skilled care, a nursing facility. That's terrible. We have to make our students able to treat the vast majority of these patients. So the definition of a disability is wide-ranging, and I'm going to take a cop-out. I'm going to just use the Americans with Disabilities definition of this, and it's a fairly wide definition: a physical, mental, cognitive, developmental condition that impairs, interferes, or limits a person's ability to engage in certain tasks or actions or participate in typical activities and interactions. Fairly wide-ranging. There are other things. You may have had a disability. You're always classified as still being under the Americans with Disabilities Act. But the key here is just recognizing that this is a very broad definition, and there are many people who actually may qualify as having a disability that don't stand up and go, I have a disability. Some of that is because of discrimination. Some of that is because of inability to receive the care. Many reasons exist for this, but we need to be conscious of this. I need to mention the history of disability rights in the United States. So if we looked almost from time of medicine's establishment until literally the 1970s, when a reporter, Geraldo Rivera, actually jumped out and found horrendous care and experimentation on individuals in a state institution called Willowbrook, and brought this to light in the early 1970s, that all of a sudden a consciousness came up. Physicians, well-intended physicians, told families, this child will be, and at that time the term was still in the diagnostics, profoundly retarded. The best thing you can do is give this child over to the state. Life expectancies were low. They received poor quality care, and there was a neglect. By 1975, the world was well aware that this was wrong and we had to do things differently, and large state institutions have almost totally disappeared, fortunately. And the patients with disabilities are our next-door neighbors, the people that are in our families. They are in our primary and secondary schools. We need to be able, as a dental population, dental caregiving population, to recognize that the patients we're talking about are no longer centered in developmental centers, often some remote area isolated from the rest of the country. 75% of people with intellectual and developmental disabilities actually live with their family today through their lifetime. A burden on family when their own dentist or their own oral health care providers can't deliver care to this segment of their family. 25% of family care providers are over the age of 60, which means that this is about to transition to an even more critical moment where both the caregiver may not be able to deliver care, and the person with the disability will now be out searching for somebody who can deliver the care. We need to recognize that almost half of our, three-quarters, two-thirds of the population with disabilities are not classified as children. Yet the only area of dental education that is actually specialized and taught the skills religiously about how to care for persons with disabilities is a pediatric dentist and pediatric dentistry, with very heavy dependence on use of sedation and general anesthesia, which has a whole additional societal cost. The number of pediatric dentists that speak with us routinely about the fact that they treat 30-year-olds weighing 300 pounds in their office, not because they want to, but they have nobody that can help them. It puts an imperative on us to change what we're doing and how. So I asked some simple questions. Should every graduate be able to manage the caries of a patient with Alzheimer's disease in a nursing care facility with a caries management product and dietary? And should we just be able to say that every dentist can do this? Should we be demanding that as educators? Should every graduate dentist or dental hygienist be able to know how to desensitize a patient that's afraid or unable to sit in the dental chair? And that goes especially for a person that might be on the autistic spectrum. It takes time, it takes caring, but not a whole lot more than that. Should every graduate be able to develop the accommodations to treat 80 to 95% of patients that present with disabilities? Treating them with respect, learning to communicate with both patient and caregiver such that everyone can get better oral health care. So the question that actually comes up is, how do we innovate the dental education process so that we can teach every dental graduate to become exceptional in delivery of care to persons with disabilities through their lifetime? Can we effectively teach our students to accommodate and communicate, listen and look at the patient as well as the caregiver, and to find the accommodations necessary to provide effective health for a wide range of disabilities and patients with disabilities? You know, sometimes it's as simple as making a toothbrush fatter, such that somebody can hold it. And this could be a patient that has severe arthritis. It could be a young patient that just does not have the dexterity. Every one of us has this capability. Have we put that thought into our students such that they can think about this and make this happen? Can we come to an agreement that every graduate has to have true competence in treating a wide variety of persons with disabilities? Not just a brief exposure, but actually a competence in being able to do this. Can we collectively agree that the curriculum must place as much effort in teaching treatment of individuals with disabilities as we do to individuals that need dentures? Why would we take 25% of the adult population and essentially say we're not going to build to competence to treat them when 15% of our population needs complete dentures? And yet we all make that strain, the laboratories, the processing, the work inside our clinical environment. Can we agree that all students, all schools have to have a curriculum that addresses the inadequacies of how we communicate with caregivers? We learn how to do this with the pediatric patient's parents or caregiver, but how much time do we spend teaching how to deliver this discussion with an adult caregiver? Can we collectively agree that we need to change the reimbursement because it is just totally unfair? Now, CODA has put on us the mandate that every student must provide, every school must provide experiences that include patients whose medical, physical, psychological, social situations make it necessary to consider a wide range of assessment and care options. Unfortunately, they give us two outs. One, it's as we define it in the school. And I would ask every school to please violently protest and not accept a definition that doesn't drive towards competence in care. It's not right for society, and it's not right for dental education. And if we do not do it, we're going to be confronted with the problem that somebody's going to direct someone else to do this. And dentistry shouldn't give it up. Referral as the mainstay cannot be the standard. So I asked the question, is it a disability? If a person is deaf and cannot hear, is that a disability? By the Americans with Disabilities Act, it is. But if they speak sign language, if they read lips, are we just having the problem that we're not speaking the right language? It's an accommodation. We would never say that a person who only speaks Spanish and I don't understand Spanish has a disability. We have to find the accommodations that will allow us to communicate and work with that patient. So, Penn Dental Medicine had the good fortune of a dean that was extremely committed to making this part of the standard of education and patient care. We came in and threw out the previous concepts of curriculum and where students would be educated. We looked at what it would take to have students receive a substantial education. Our students spend one morning or afternoon every day for a comprehensive year in a Center for Persons with Disabilities, the Personalized Care Suite, where they deliver care to a wide spectrum of patients without general anesthesia. And they become comfortable with this. And there are some students that just aren't happy with that. But there are also students that aren't happy learning dentures. It's part of our mandatory curriculum, and it makes us better people for it. We teach them how to deliver care and communicate as necessary with caregivers, and it's more than a goal. We have managed to make it a reality. We do teach our students, continuing education and others, to communicate with caregivers and to communicate with patients and provide accommodations that make this successful. We focus on every graduating student. It is mandatory with competency examinations and performance objectives. We provide health care for the patients who have a disability in an environment that helps make them feel more comfortable in being part of this with us. And we provide ongoing continuing education, which is available to everybody, as well as immersion experiences to help bring other dentists into the realm of being able to treat. It is possible to make this a reality in every school if we make the commitment to do so. You're all the people that have the possibility of making that commitment possible, and I think that it's critical that we all do so. Thank you.
Thank you, Dean Wolf. Exactly, we can all do it, and we can all do it together if we sort of just focus on the things. Next, I'm going to be bringing up a presenter, American Academy of Developmental Medicine and Dentistry, AADMD, has as a charge and a focus to help intercollaboratively bring awareness to the overall health of someone with individual and developmental disability. We call it a One Voice for Equitable Health team. Another organization is Special Care Dentistry Association, another excellent organization with great resources helping elevate people and taking care of things. So the AADMD had a program. It's focused on three parts. It's on advocacy, education, and access to care. And one particular important project was that it's called a niche program. It's called an NCIDM program, National Curriculum Initiative for Developmental Medicine. And with us today is Dr. Priya Chandan, and I'm going to bring up Priya in just a second here. She is an amazing educator with a great background story, very compassionate. And Dr. Chandan, do you mind sharing with us the story about the niche?
All right. Can everybody hear me? Think we're good? Yeah? All right, so I'm going to share slides with you today, but I also realize you guys have the slides, so I'm hoping to leave time for discussion so that this can be interactive as well. We tested it. Can everyone hear? Thumbs up. If not, I'll scream louder. I just don't want to blow out your ears. All right. Okay, so what I'm here to do today, thanks Dr. Wong for the introduction. I'm Dr. Chandan. I am a clinical associate professor at the University of Louisville. My background is in physical medicine and rehabilitation. It's the worst named field in medicine. File it away in your head for now. We'll come back to that. But over the past 5 years, I've been able to be the project director for National Curriculum Initiative in Developmental Medicine. We are changing the name to niche, and I'll go through why and sort of what's next. But my goal here today is to bring sort of an overview for you guys on what's happening in the medical education space, again, recognizing that it's something that shouldn't be done in silo and that we're hoping to collaborate more with dental education as we move forward. I think a lot of the concepts definitely cross-apply. So, first step is talking about some of these terms. And so I realize people here today may understand these, but I always start, no matter the audience, let's get on the same page in terms of these terms and how do they relate to each other. It's a lot of word soup out there. So health equity is a principle. And in that sort of state of equity, everyone has the opportunity to attain their highest level of health. I like communicating in words and in pictures. In this case, I think the picture tells all the story that you need. What we emphasize to our med students is, think about equity. The choices we make depend on the choices we have available to us. Choice is incredibly important for equity. We'll apply that kind of in the context of patients with disabilities. The other big topic I feel like that comes up a lot is social determinants of health. And so those are the conditions and the places in which people live, learn, work, and play. Again, I think the graphic tells the story here. The main thing I try to point out to our students is, you see healthcare access and quality, that's a small part. What we end up seeing in that sphere is a product of the social determinants of health in all the other spheres. So education, transportation, healthcare financing, economic stability, all of these things relate to health outcomes. And so our job is to kind of think more upstream as to where is the source of the problem, again, with that prevention mindset. So again, being clear about health disparities and healthcare disparities, you'll hear both of these terms. They're relating to sort of a difference in outcome, but the difference between the two terms is, what are we attributing that cause to? What is the root cause? Is it related to social demographic factors, or is it related to factors inherent to our healthcare system, so insurance, access, quality? Think of it this way: disparities are a measure towards achieving health equity. I like to say, if one day we achieve equity, awesome. We won't see any health disparities, we won't see any healthcare disparities, I won't have a job anymore, it'll be great. But that's how we know how we're doing. And based on that, we know we have a long way to go. Dean Wilf sort of illustrated some of the prevalent statistics, sort of the state of the problem here. But again, we have to go from just not documenting that there are disparities, but moving from the theoretical to what are the root causes of those disparities. And so that's really kind of where our conversations are centered now is, yes, this is what we see, but why do we see it that way? And what can we do? And in the context of clinical care, I'm probably not going to be addressing some of the root causes, but I can advocate in the health policy sphere for things that would address the health and healthcare disparities, and I can also tackle the things that I can do, and there are a lot of those. So in summary, health equity, that's your guiding principle. Health and healthcare disparities, measures of health equity, and social determinants of health are really those root causes. Now, that's kind of unpacking some of the terminology around health equity. We also have to do a lot of unpacking of the word disability. Dean Wilf presented the definition for us. Another thing that we're challenging our students to do, and faculty, is how do you think about disability? Those conceptual models is the fancy term, but how do you think about disability? And I'll go through some concrete examples of ways that we are doing this. And so we generally start out by saying there are many different ways to think about disability, and they can and they do overlap. But step one is to do self-reflection, self-education on how do you think about it, because the way you think about disability is going to affect how you then teach about disability. And so briefly, we kind of go through with our students, there's the medical model. The problem that it can lead to is diagnostic overshadowing, so that is where you are attributing you're making an error in clinical judgment. You're attributing something to the diagnosis of disability when in fact that may not be what's happening at all here, but there's a quick jump to do that. The social model and the functional model, or as I like to call it, both. The functional model is one where we think about aspects from both the medical and the social model. And the idea here is an approach. So when we talk about NCIDM, the National Curriculum Initiative, I get asked all the time, well, what is the curriculum? And they're expecting sort of a box that this is the curriculum. But really what we have to do if we're going to impact health outcomes is rethink our entire approach. And that is what is happening in the medical education side. And so the ICF, we're all very familiar on the medical side with ICD 9 and 10 codes. We're used to coding. The ICF is another categorization or schema from the World Health Organization, but I find that it is very helpful for thinking about how you approach really any patient. And so it's also helpful because you can think about a patient at the individual level, which is where we sit most of the time clinically, but at the population level as well. And the key is that it puts a person into a context. So concretely, let's walk through an example. What do I mean by that? First of all, you'll notice the contribution from some of the social models is thinking about the environment. So previously, we didn't do a good job of that. We saw the patient in front of us, we saw their problem list, their list of diagnoses, that was the patient. But we're realizing, again, because of social determinants of health, you can't ignore the environmental context. And the environment includes not just the built environment, but perhaps the attitudinal environment as well, if patients are facing discrimination. So that's the first contribution you see. The next is, we're very good in medicine thinking at body functions and structures. That's where we live. That's the clinical care. And it is not to say that it is the responsibility of physicians or dentists, of clinicians, to address all of these things all at once. That is why we have other health professionals. That is why we do work together in teams. And I think when you sort of think about this applied for a particular patient, you can see where that teamwork comes to play. So I use this example, again, it's in the slides, so I won't walk through all of it, but essentially if you see a patient, maybe the patient is male, 30 years old, has a spinal cord injury up at the top, that is sort of the diagnosis. And then we think about all the different sort of ways we might provide care for this patient. And I think this slide does a really good job of that. So again, the health condition or the diagnosis, spinal cord injury, okay, great. There's ways we can think about intervention as well as prevention. And some of those I can control as a physician. Some of those are under sort of my scope. Some of them are outside of my scope, but I know it's important. And at the very least, I need to know who does what in the health profession space and know which friends to call to provide holistic care for a patient. So me being physical medicine and rehab, management of spasticity is something I'm often doing. And that is important because it then allows other health professionals to also help me with that. And also if I can improve this patient's spasticity, it will help my colleagues do what they need to do with that patient. We talk about lots of different examples with that. And then, an particular activity, I'm often talking to my physical therapist friends, so that's why we put ambulation up here. But it could be brushing your teeth. It could be any activity in the context of health. And then participation. I think, I won't elaborate too much. I think we know for patients with disabilities, use of public transportation, can they even get to the appointment, becomes an important thing to consider. So again, this approach is something because there's implications for clinical care as well as research, as well as teaching. And so you may be thinking, that's all great, sounds good, but what can I do? So I will leave you with one example, one case that you could do with your students and with your colleagues to help them think about the approach to patients with disabilities. So we walk through this, again, it's a self-education or self-reflection exercise. So I present a clinical vignette to my colleagues, to my students, grand rounds. I say, all right, so today we have a 37-year-old male. He is Indian American. He works at the Atlanta VA. He taught himself Spanish, and he also plays piano. He is presenting today because he hurt his knee playing soccer. And so that's kind of the patient I present. And then I say, okay, so is this person disabled? And overwhelmingly, everyone's like, why, what? No, why are you even asking me that? And then I say, okay, now I'm gonna add one thing to his problem list. This patient has Down syndrome. Now, is this patient disabled? And then I get I And the problem is the medical model, the way we've been trained to think, puts disability in a binary. My learners, my colleagues are expecting to answer me yes or no when it comes to disability. And what we see is, the ICF, there are others, but really you just need a deeper dive. Disability should not be equated with the medical condition or the diagnosis. You have to take into sort of the context there. But really, I think if nothing else, that's a good conversation starter. It helps people realize the limitations of maybe the way they're thinking about disability. And then I like to always bring it home, that vignette that I told to you in the beginning, that is my older brother. So this is something I'm very used to seeing because describe him one way and he has a disability. Describe him a different way and suddenly he does not. And that teaches us that disability is a social construct. Now, there's a couple other concepts that I'll go through that I think are important to address here. And again, if we're thinking about equity, we have to realize that as clinicians, we are part of the environment a patient experiences. We are part of that context. And so our thoughts and our actions can serve as facilitators or barriers, potentially, to health equity. And so this, again, is in your slides. I really like this article. I think it's, it comes from the AMA, but it really is valid across disciplines. It says, what are our responsibilities? And so the first one is combating ableism. And to do that, we need to know sort of what do we even mean by ableism? How do we get there? So again, we go through kind of the thought of the importance of the environment, attitudinal environment, and attitudinal environment or biases, that's where ableism comes in. And so there is a study that came out recently that has brought up a lot of discussion in our field. And the idea is that physician bias, ableism, let's call it what it is, step one, ableism, is a determinant of healthcare disparities. And so what this study eventually sort of looked at is it was a survey, it was about physicians' perceptions about patients with disabilities. And those perceptions raise concerns about whether us as a workforce can actually ensure equitable care. And the reason is, and I won't read it, but you see sort of things like this. So if this is the attitudinal environment we are working with, we have a lot of work to do before I can even get into clinical considerations about patients with disabilities. And, this is the idea that bias is important. It's a first step that needs to be addressed. Absolutely, we need to have conversations on clinical care guidelines and providing clinical care. But we have to unlearn some things before we can get there. I will say, too, that this study in particular left out physicians in physical medicine and rehabilitation. Why? Because we only see patients with disabilities. And the thought is we're supposed to know better. But I will tell you on behalf of our field, we're having a lot of conversations right now that we don't, and that there's a lot of work to be done, even in physical medicine and rehab, where every single patient we see has a disability. And so again, this really brings it home is if you're a patient, what if your only choice is a biased clinician, or maybe a biased and an untrained clinician? What sort of health outcomes are you going to see? Well, you're going to see the health outcomes that we see currently. And we cannot discuss ableism in a silo. So this next piece sort of ties to that. First, defining ableism. So the belief that typical abilities are superior, the assumption that disabled people require fixing, and defining people by their disability. And just like any other form of discrimination, this classifies an entire group of people as less than. And that's what we see very prevalent in dental, medical education, health professions education. But we also see it in society. Think about it. If you start looking, you will see it everywhere. Failing to incorporate accessibility, and I mean physical, cognitive, or sensory, and restricting treatment choices based on a disability diagnosis. There's also a concept that we're reckoning with in medicine right now called internalized ableism. And that is where, as physicians, we prioritize our clinical competence over everything. We are taught to do that. And so how, in some ways, is that harmful when we then view patients with disabilities? We have internalized ableism, and we sort of make the mistake of their life isn't of value because of their IQ. that is a problem. And so having discussions on that. Even, thinking about signs, nonverbal communication is important too. And so the point here, we've talked about 1 in 4 adults have a disability. Then we cannot disentangle our discussions in the disability space from the health equity discussions more broadly. We often silo that when we're talking about clinical care or when we're talking about education, just given expertise. But because this is sort of a broader issue, we have to work together and we have to sort of bridge the gap to come together. And I will say that all of those categorizations, if you think about it, are made up and are false. People living their lives don't exist in those silos. You can at the same time be experiencing racism and ableism at the same time. And so this is really just saying, marginalization within the disability space, we have to be cognizant of the double burden faced by people of color within the disability space. And that's another topic that I think is sort of becoming more of a focal point. And that's intersectionality, but I'm going to skip the COVID example. But again, communication, another topic that we sort of go through. I bring this up just to say this is an opportunity where you can be intersectional in your teaching. So if you're talking about identity first, person first language in the disability space, it's a great place to have a dialogue about pronouns as well. So we've seen that in some of the medical education work. So elevating self-advocates is incredibly important. I don't have to go through this with you guys because this audience knows about the great work that's happening in dentistry and how there's potential there to see some leadership from your field in these areas. Dr. Wong mentioned, NCIDM, so I will just say briefly, happy to talk more in the Q&A. But the purpose here was developmental medicine across the lifespan. We've been successful in bringing 20 medical schools together, 5,000 plus medical students reached. And again, it's an approach to medical education. And so these are the key pieces. The approach has to have clinical and didactic components, in-person interaction, lifespan focus, and internal champion. There's lots of different methodologies that you can use. I think this is where we tend to get caught up when people say the curriculum and they're like, well, which panel do I need to have to check the box on and we have to think about sort of the approach. We did create an attitudes and a knowledge survey. Again, I'm happy to talk more about data and evaluation. That's my life, that's my love. But I think the point here is that this community engaged approach, so centering self-advocates, having them be teachers, was effective. And again, you can see that sort of in some of your slides. I purposefully gave you more content than we would have time to talk through today. But I would say that, think about it this way, we are seeing a big paradigm shift in medical education, the unlearning aspect. And so teaching our learners and our colleagues how to think, talking about, like comfort versus competency. Well, why are you uncomfortable? We need to teach our learners how to address those feelings that come up in providing clinical care. And then infusing disability into any topic, but also being a good partner and partnering with other efforts. And so in the spirit of that, I will come to here, this is where we're going. So niche medical, we are sort of bringing other schools on board, centering, again, that lens of ableism and how we think about disability. But at the same time, we've learned over the past 5 years that in moving the work forward, there's some key areas we need to partner with. So one is with dental, interprofessional education. So I'm happy to talk more about that. But essentially, we're trying to help support educators and grants to look at this work. And then also intentionally centering other health equity groups. So can we partner with HBCUs that are working on the anti-racism curriculum efforts? Partnering together is the only way to address such a large call as this. But the overall idea, and I'll leave you with this, is that if we can teach our learners and our colleagues an approach to patient care, that's how we get them to provide culturally competent and compassionate care to all patients. And when it comes to patients with intellectual and developmental disabilities or disabilities more broadly, that is a great illustrative example to help our learners learn how to better provide equitable care for all patients, period. And with that, I will turn it back to Dr. Wong.
Amazing presentation. Thank you, Dr. Shannon. We're going to call up Dr. Frey in just a little bit, but can you imagine the situation where someone with IDD has 20 years less of a lifespan than someone that's neurotypical just because of intellectual and developmental disability, and it's because of WNL. We never looked, or we never bothered to look, but we need to start looking now. So I'm going to bring up Dr. Frey, and for our next segment, there are QR codes being passed around. Feel free to click on that for the Ask Me Anything section. We'll try to answer some questions shortly, and there is a time for questions and answers at the end. Thank you. You got 9.5 minutes. Feel free to click on your QR code there if you have any questions you want to type in there while we're getting set up here. Thank you.
Take a look at these pieces of paper that are on your table. And be thinking, actually, you're going to multitask here. I'm not going to read my slides. What I would say is that you can read them faster than I can share them. But what I would want you to know is that you've heard the why. My part is the how. And when you look at the theme of our meeting, Believe I'm Possible, we actually can say together, believe we're possible. Because the people in the room represent dental schools that are already doing much of this. But we need to be more collaborative together to make a difference. So I would encourage you to think about doing a few things. One would be, after the meeting, go to the back table in the room and scan the QR code, grab one of the flyers, talk to Nicole. If you want to be a contributing author, we have over 80 contributing authors and authors and contributors to the curriculum project. We have shared resources. We have shared syllabus and PowerPoints and OSCEs and all kinds of things like that. But we really believe that we can make a difference, and we can make a difference in how we think about disability. So I would want you to realize that every school is going to do it different. There is curriculum project goals. The scope is to pilot this in dental and dental hygiene schools. And then ultimately, as Dr. Shannon was saying, we want to create a national inclusive curriculum in health education that is interprofessional. And so we've started to do that in our school with our medical school and our nursing school. This is a really good nexus to interprofessional education to focus on how can we collaborate to get better health outcomes, and how can oral health be a part of overall health. And that's extremely important. So we want to take the curriculum and look at the need, build on what we've done with NCDIM and ADMD over the last few years, and then embrace the challenge. So these are the sections that we're currently working on that involve oral health. And then what I would say is that as you go back and look at these slides, take them home, think about it, be talking to your faculty. And I would say a couple other things you could do. The annual meeting for the Special Periodentistry Association is coming up April 27th to 29th in Dallas. The annual meeting for the AADMD, and these are kind of sister organizations that both support this curriculum project. The American Academy of Developmental Medicine and Dentistry is in Denver in May. And so encourage your faculty to be thinking about how do we braid existing courses with information from case studies. And so that's what we did and what we continue to do. We want to look at this and say, can we collaborate on curriculum? Can we together, the people in the room, the dental schools, our current curriculum project has approximately how many, Dr. Wong, dental schools?
17.
17 dental schools. We'd love to get all dental schools involved. Can we deliver on the educational competencies? Can we agree on the competencies? Are the oral health disparities of adults, can they be reduced? Our pediatric dentists do a fantastic job. But remember, they only serve, as Dr. Wolf pointed out, less than 8% of the population. And so it's really disturbing to me to see that people, adults with intellectual disability, have documented deaths from untreated dental disease. That's just inexcusable. And I say that to you because I was the director of developmental disabilities
for over 18 years in 2 states. And I was shocked to find out that people didn't have access to oral health care and couldn't get an abscess tooth treated in time to prevent Ludwig's angina and death. And that actually happened. So I think we can do better. I think we should do better. And I would ask you to look at these questions. What's the status of our clinical training? We know experiential training makes a big difference. If a dental student experiences a patient with autism, they are far more likely after they graduate to want to treat that patient. But if they don't, they're far more likely to have that ableism and that bias. So we really need to work on this. What are some examples in our schools, and can we share, can we cross-pollinate ideas? Can we share faculty? Are there ways that we can do things? And then the last question, what facilities are needed? I think a lot of times people think that if you want to serve special needs patients, you need to get a lot of money and build a different clinic. And I want to show you a picture in a little bit, a real creative way that a dentist in Sugar Land, Texas, which is a suburb of Houston, actually solved that problem. So we can basically collaborate, we can be evidence-based, we can agree on objectives, we can map our curriculum. At our school, we're working on artificial intelligence things of where we want to find how to map that curriculum. You can look at these resources. This is actually, these next few slides are about competencies. We need to establish common competencies. These are things that SCDA and ADMD and ADIA and CODA, we can all work together on this. And so these things are in process. We, at SmileCon in Las Vegas, the ADA passed Resolutions 46, which says that we need to work on this stuff. So I would encourage you to go back and look at that resolution. If you want to get involved, we have a Resolution 46 committee in SCDA. We want to work on these types of competencies, communication, humanistic skills, patient care skills for all patients with IDD and special oral health needs. I really like, Dr. Wolf, your comment about graduates being 95% of patients with disability. Graduates need to feel comfortable, but they also need to know where they can refer. We need to fix the problem that pediatric dentists keep bringing to the table. I have no place to send this 35-year-old with autism that's nonverbal. And as a profession, we can do it. So the theme of the meeting is believe I'm possible, believe we're possible. We can do this. It is within our power. Now, we don't control legislatures, we don't control reimbursement models, but that is a key thing that we as a profession can continue to work on. And so I would tell you to envision something that's a little bit different. This is how we weave or braid case studies with Down syndrome into our first-year course of clinical applications. And this was how they study the different systems of the body. And so these are things that are examples that you can look at that I've included in my PowerPoint, how we do this. This is a respiratory case for a patient with Down syndrome. And so airway issues exist. And I think this is another case. This is a geriatric case. I'll encourage you to look at the virtual grant rounds at the AADMD website. Also go to UPenn Dental. The free CE there is fantastic. These are things that you can incorporate into your undergraduate, your pre-doc programs, and then the facilities. And this is a slide I wanted to camp out on for a second. Dr. Jacob Dent is a dentist with a 19-year-old son with autism, and he's learned the hard way what works. And when you look at the picture on the right, you'll see a room that the outside door opens to this room, so you're not going into a normal dental office. He uses this room for speech therapists, occupational therapists, board-certified behavioral analysts, and so this room gets paid for because they bill their medical insurance. This is a collaborative care model. And so if I could tell you, we could eliminate the failed appointment by doing a different approach and look at how we incorporate oral health care into overall health care, we can actually solve the financial problem that is the biggest barrier. Because the old way, people call and the dentist says, okay, we'll see your child, and they come in and it's a failed appointment. The first thing they try is maybe putting a sensor in the mouth to take a bite wing. The environment feels scary. It doesn't work. Oh, I'd also point out, after they graduate from this desensitization room, you see the beanbag chair. So what facilities are needed? A big room and a beanbag chair. I really want to drive that home. It doesn't take a ton of money to solve this problem. It really doesn't, but it does take a different way to think about disability. It takes thinking about function. So I have 1 minute. So this is the collaborative care team, the policy changes. You can see this. I think this is a striking thing. Dentists don't participate in Medicaid because Medicaid was set up to underpay for procedures. That is a basic fundamental problem, and dentists can't make money doing it, so they don't do it. Physicians participate at twice the rate So it's a really interesting thing, but they're both paid at about 60% of the usual and customary fee. So we know that we have a problem. This was what I was talking about, the resolution that was passed by the ADA in 2021 in Las Vegas at SmileCon. And then the last thing is, I don't know of any other disability group that has a federal law that says you have a right to appropriate dental care. But the DD Act of 2000 says this. It's an unrealized promise. I'm very proud of President George H.W. Bush signing the Americans with Disabilities Act in 1990. He's from Houston. And that's an unrealized promise. It says we're supposed to do it, but we don't do it. But I will tell you that the answer is in the room. We can do it. We can actually change the model that we teach. We can change the attitudes of people, and we can teach collaborative peer-to-peer monitoring. We can take people with disabilities to teach other people oral health. They don't have to learn it all in a dental chair. There's so much that can be done before they ever show up in our office, and we don't have to pay for that. We don't have to charge for that. The Medicaid home and community-based waiver programs exist in every state. They will pay for those therapies. Thank you very much for listening. And now look at your piece of paper, and Dr. Wong's going to guide us through the questions.
Thank you, Dr. Frey. As I said, like 20 pounds of grocery in a 10-pound bag. Anyway, so the next segment actually is my segment. It really just outlines what the curriculum project is based upon. But I want to take this as your moderator, take this time to have a conversation. So we're going to open this up for about 10 or 15 minutes for questions and answers, and go from there. So are there any burning questions out there so far? Don't be shy. No? Yes? Comments? Concerns? You're just waking up, not enough coffee. Just come to the mic, please. There's 2 mics right here. And, or if you can yell loud, go for it. Yeah, come on up to the mic. Don't be shy. I'm not going to bite. While they're doing that, you know, another disparity of care we think about, this is implicit bias type things. We talk about Alzheimer's, a disease that's being diagnosed more and more. Do you know that patients with Down syndrome start having symptoms of Alzheimer's at the age of and dementia in 30s and 40s? Are you aware of that? Do you know that a lot of them have sleep apnea that we don't even think about diagnosing or referring to our orthodontist? This is the equity issues. Questions?
Oh, hello. I'm Professor Margaret Cox, King's College, London. I'm not a clinician, I'm a dental educator. And one of the points you made during this really interesting presentation, which you meet in other areas as well, is that when you want the students to learn about these things, which is so important, then often those in charge of the curriculum say to themselves, well, what should we cut out so that we can include this? And I think one of you said that quite early on. And that's a real challenge for everybody. And I wondered if you'd like to comment on strategies that one could take back to the school and say, well, you know, you could include this and therefore you, because the curriculum is just so full already.
I can address that. I'm on the curriculum committee for many years, and we made the conscious decision to braid case studies into existing courses and not have additional courses.
Thank you for coming all the way to King's College. In some countries, special care dentistry is a specialty, and King's College does an excellent job. Colleagues over there, there's an organization called the IADH, the International Association of Disability and Oral Health, and our friends over there really got it dialed down. But it's not taking out, it's enhancing. So thank you for being here. Yes, question?
But I do want to comment. I do believe it requires special attention in the curriculum because it goes beyond case presentations. It is clinical in scope, and students have to become comfortable. Students, residents need to become comfortable with interacting with individuals with differences. And it has to become an integral part. It can be a denture made or a crown made or a restoration done on a person with a disability should be treated actually a little bit they've achieved a higher outcome than what was done in the comprehensive care clinic.
Thank you, Mark. Question?
Yeah, thank you so much. Nadeem Karambak's the Dean at Tufts University School of Dental Medicine. We actually have 7 clinics in the state of Massachusetts called the Tufts Dental Facilities. We have 7,500 registered patients where we meet their needs in those clinics. It's a unique operation because in the state of Massachusetts, there was a lawsuit about access to care. So in 1972, the state and Tufts have worked on delivering that care model. It does take a lot to have faculty and staff in those sites. But some of the challenges that we see are kind of the one-off. In other words, students go in either half a day, 5 days. So the continuity of care certainly is a challenge. We need to think through that. The other challenge that we're having is access to operating rooms. A lot of times these patients do need that kind of access. So more and more we're finding hospitals are cutting out dental. So for example, our patients go to a hospital called Franciscan, and we're worried about losing that site. So I'm wondering, how we meet that challenge given the environment that we're in and how we educate our health professional collaborators like those in medicine to try to piggyback with us to deliver that care. And love to hear your thoughts around some of those items. Thank you.
Thank you. Let me, I'll take the liberty. Thank you. Great questions. There are a lot of opportunities. We need to grow these opportunities. Many postdoctoral programs have people that are kind of trained, and we need to sort of focus in them as new educators. And Special Care Dentistry Association is one of those vehicles that we can help them to grow to that next level and be that future educator. But we need to plant the seeds. We need to bring them back because they want to teach. They want to help out in this area. And in terms of operating rooms, that's a problem we're not going to be able to solve totally. But there's a disproportionate amount of energy being focused on prevention. And I think that we can work on prevention earlier. We won't have to worry about this operating room crises. We still need to deal with it, but I think we need a lot more attention, which our curriculum addresses. Does anyone over here want to talk about that?
Yeah, I would say, that's certainly a real challenge. We face the same thing, but I think what we're trying to do is to say, if the only time we're thinking about this education is once we're in the OR, it's too late. And so looking at what are the opportunities, again, in the preclinical years to teach them the approach. I'm never going to have specialized time, to go through every single type of patient that may present in your door. But what I can do is say, let me teach you how to approach a patient. And fundamentally, let's make sure that approach is free from bias, free from ableism, racism, et cetera. And so I think, I would advocate that that's a strategy. And to address the previous question, one strategy we've seen that works really well is going to your school as a partner and saying, I go to my medical school and I say, what do you need covered? Because if I'm saying that this will make people better at seeing all patients, I really mean that. Give me any topic and I can do it with a disability lens. So now we do the lecture on healthcare financing, Medicare, Medicaid, the basics 101. That is now used with a lens of disability. So we go through, why is it called a waiver? Because you're waiving your right to live in an institution? That's interesting. Let's talk about how we got here. But so again, all of that to say, I think that we're looking sort of downstream. If we look more proximal, then there's things we can do so that we don't end up in that situation down the line anyway.
And also the collaboration with behaviorists and whatnot in terms of managing expectations and helping people to become better and healthier, utilizing some of the newer techniques, silver-diamine fluoride, prevention, not having to use local anesthetic for simple fillings, atraumatic restorative techniques. These are all viable things that we can start teaching and thinking about. Sydney.
Hi, I'm Sydney Chavis. I'm from the University of Maryland, Baltimore. Incredibly appreciative for this session and this panel. I have more comments than anything, but I have an older sister who has pretty profound disabilities, which is, I know, what has driven me to this field and to this niche, so to speak, of dental care and healthcare. And I know, Dr. Chandon, it seems maybe it's similar for you. I think an important focus from a curriculum-based standpoint is, of course, being person first, but I find that in education we get so inundated with what are the requirements, what are the accreditation standards, what's the minutia of day-to-day that would then lose the bigger picture, but that's what makes it so difficult to fit these equity-based practices and equity-based education into the curriculum. So I think kind of framing it from a standpoint of what's your purpose for being here, right? Kind of getting to the humanity from a student basis and kind of building a curriculum up from that and getting people to understand why does this matter? Because I find for so many things, you get busy, you get concerned about your grades, requirements, et cetera, that you lose the connection. And unless somebody understands why is this so important or what are the struggles that people face out in the community, why are we beholden as a profession to do this? So it's more of a comment than anything, but I think that the interprofessional nature, the equity-based nature, the social determinants of health, all of this has to be incorporated throughout the scope of the entirety of the curriculum, clinical and preclinical. And I mean, I'm sure it will take years if we can ever actually accomplish this, but I think it's just being creative in terms of how we as educators frame that. And I know that I will just say we have a special care clinic at University of Maryland that becomes a punting ground for difficult patients that other dentists don't feel comfortable treating, other faculty don't feel comfortable treating. And if that's the example that we're setting for students, then it just sets the stage for when they get onto practice, they can refer whomever they want to back to the clinic. So kind of making sure that all faculty on board and it's not a siloed thing within the curriculum and that it's really a comprehensive effort within professions and across professions. So sorry for my rant, but I just, it's nice to see this forum here and I'm very appreciative, so.
Great, thank you very much. Thank you. Well said.
Avoiding that punting is very important, but I think everybody just has to recognize you have to take this from a population health standpoint of what we're teaching. If it's CAD/CAM, if it's dentures, how do we allow our curriculum committees or our faculty or school to relegate a portion of care to an ancillary? Well, it'll get a couple of hours, or it'll be done digitally. It'll be done on an online. I think we just have to resist that.
Right. So we do have a question, and a lot of times I feel like it's like I'm Alan. I do special needs dentistry, but it's a therapy group. But it's not a person's job; it's everyone's job to make awareness to this. But the question is there an example of successful merging into our pre-doc restorative dentistry curriculum that you could share with us? I'm wondering how to incorporate this training at our school. Should I suggest serrated new course in community dentistry, or sprinkle of teaching throughout multiple general restorative treatment planning and comprehensive care courses? These are the courses that I direct. I have one child and 2 adult children living with autism at home myself. Thank you. I have an answer, but does anyone on the panel want to address it?
Yeah, I would say, again, that is a great question, and I encourage everybody in here to think about what are you the gatekeeper to? We're all educators. There's some place you have where learners are going to learn whatever you deem is important for them to learn. And so, again, I think starting at sort of the approach, doing some of that work so that their understanding of how they're thinking about disability and sort of how that can play out into the care that they provide, I think is where I would start. And that can be built into any course, into any environment, whether I'm giving a lecture or didactic or whether we are in the OR together. I can talk with my learners one-on-one about that. But I think that's where I would start.
You can have a disability lens in any course. So PROS could have one on treatment planning for people that are nonverbal and people that might not tolerate a removable. So there's a lot of ways to look at it. We're thinking about doing in our ethics course on health, emphasizing health disparity, but including our students having to rotate in an outside rotation and come back and being able to share what that experience was like. So I think there's lots of ways that you can incorporate it, creative ways, but I do think that it has to be intentional for all parts of the educational process. You can't just say, well, we're not going to have a course in disability, but if you're going to have disability lens, you put them in all courses. Yeah.
I totally agree. We're not suggesting we create new courses in this. We're just increasing the lens of the spectrum of what you're doing in that course, whether it's restorative or whether it's removable. How would you do it in this population situation?
But measure the outcome.
Yeah, that's right. Question.
First, thank you so much. This was amazing. we have our own special needs clinic, and we have, the question that you just answered, we do have discrete courses on special needs. We used to give it in D2 year, now it's in sort of the D3, D4 years, and students rotate. Every student rotates through the special needs clinic. Still, I think your, Dr. Wolf, your comments, I think all of you actually have made those comments about prevention. I think that's where we need to focus on. And I can't remember, I think it might have been Dr. Wolf, your slides, you had some sample sort of statements that CODA could adopt. But I think defining management, management, of course, prevention is under that umbrella of, treatment and prevention go under the umbrella of management, but defining it further, equipping all students to be able to just modify, the toothbrush or flossing techniques for those who need it, where to stand for the parent or the caregiver for a child with disabilities. How do you teach the caregiver? Providing that education should be the focus. If it comes from CODA, if it comes from all bodies that give grants, they should, if they give a grant to treat people in the OR, at the tertiary level, then there should be a portion that must go towards prevention. You must demonstrate that you're doing enough to, or substantial amount in the area of prevention. I think that is major. If we don't do it from that lens, there's no remuneration for it, so it's difficult to change behavior without remuneration.
So there can be reimbursement for it. And I think that's what people need to understand and to learn. And so, go ahead.
Okay, so let me slip through, I only have a few minutes. Let me slip through this a little quickly here.
Come talk to me later.
So anyway, so we embarked on this project between Penn Dental, University of Texas Pacific, not for us just to celebrate what we do, but to sort of invite everyone else who has great outcomes and stuff and add it into this sort of national curriculum. And basically, Section 1 is why should we care, embracing the challenges of health disparity. Section 2 focuses on how should we modify care for improved care. Section 3 is how we improve overall health. And Section 4 are just resources. And the idea of this was to bring great minds of experts from around the country to create little mini modules of information. We call them kind of like Cliff Note version, pearls of wisdom. And then we'll have something which has PowerPoints for the facilitator that are like TED Talk-like things that are 10, 15-minute segments, so that any school that says, oh, I've got this covered, I got this covered, but I don't have this covered, they can just take this off and it'll be online and it's going to be user-free for everyone. And the concept was basically the tide that lifts all boats, that if you already have it, great. If you want to use it to enhance what you have, great. And all of these PowerPoints are modifiable to the schools as well. But at least it has a sort of a standard of what we're talking about. So I'm not going to go into each one of these, but if you want to look in the back there, our project manager's back there. But what I wanted to share with you was that the timeline that we have is pretty ambitious. We'd like to have by this time next year the curriculum project version 1 pretty much usable for everyone. So I mentioned we have 17, 18 schools that are contributing. We have a lot of people doing great things throughout the country, and that's what we want to do. We want to put everything into a pot, share with everyone. It used to be like NIH, not invented here, so we don't want to use it. This is a collaborative project that we want to share and celebrate, and we do it also partnered with this person. His name is Rick Gadati from Positive Exposure. The pictures around the room sort of show you that these are the people we're taking care of. These are not subjects. These are human beings, and we need to open our eyes, open our hearts, and open our ears so that we can take care of them in the best way we can. So some of the samples, chapters, you can see what they look like in the back. I'm not going to go through it. But we're trying to make it user-friendly for the school that is, I don't have enough faculty. We're trying to make it user-friendly for the schools that I don't have the space. So there'll be elements of pull-out sheets on how do I modify what we have, what are some of the pearls of wisdom, and how can we help each other become better. And we're hoping that people who've used it can send in some information that we can update it and have version 2 even more rich and robust. All right? I wish we could go on longer and longer, but Hubert's going to yell at me if I do. And I promised I'd stay on time. Hubert, I'm on time. Any other questions? I want to thank everyone for coming to this session. I want to thank the panelists for their excellent presentation. The slides are on the deck. And I know we can do this. We're possible. We're here to help you meet CODA Standard 2-25, but more importantly, improve the lives and health of everyone. Thank you.